Good day, students. We are meeting after a long time. Hope your IPL is all over by this time. The system that I'm going to handle now is a little weird and complicated, both for the students and the teachers alike. I would like you people to pay immense attention to each one of the classes. Even when you omit one, you might not be able to follow the rest. You will understand why as we start unfolding the renal pathology. The caption and the cartoon have been designed for the students. Two topics will be handled for the day. They appear quite simple, but let us see what additional information we can get through them. Doing things differently is a sure way to success. It is my personal experience. Here I am seeing a vehicle in the reverse gear, and that will be my modus operandi. This is the kidney, a very complex organ. On the one side, I find the cortex and the medulla, the parenchyma, that is being well supported by a connective tissue, namely the interstitium. We have got the calyx and the pelvis, the pelvic ileal system, and also the blood vessels. There is some amount of pathology that is restricted to each one of these, and we shall accordingly be seeing them. This is a simplistic diagram of the kidney, which you should always have in mind. We have got the renal pyramids, and this is the cortex over here at the rim, and it is being surrounded by a capsule. This in turn is being surrounded by a gyrotous fascia and a perinephric fat. At the superior pole is the adrenal gland, and we have got the hilum wherein we have got the various structures entering and leaving the kidney. The pelvis is a large delta-like region from which we have got the branches of the calyceal system, and down we have got the ureter. Please have this in mind. You should draw this diagram. And in today's class, this is what I am going to handle. You have got the ureter, and this leads on to the renal pelvis, which again branches off into the calyx. The calyx in turn leads to the minor calyces. The entire unit can be called a pelvic ileal system. And this is the infundibulum or the opening of the calyx. The topic for the day will be hydronephrosis. Hydro obviously means water, and nephrosis is stagnation. In this condition, I find that the renal parenchyma is thinned out. There is a ballooning of the pelvis, and so also the calyx. The calyces become so very dilated that they are fused with each other. Downwards, the ureter may be distended or not, and this is probably the site of some obstruction. Basically, a concept about hydronephrosis. And there is a progressive gradation of this. Initially, it is mild and it is restricted only to the renal pelvis. But later on, the calyces are also becoming distended, and progressively, I find that there is an atrophy of the renal parenchyma. It is so very severe that it is thinned out. In some cases, we are finding specimens in the museum where the kidney is more than 2 feet in length. There is the blunting of the calyces, enlargement, rounding that I am seeing over here, and ballooning of the pelvic calyceal system. What is hydronephrosis then? It is a dilatation of the renal pelvis and the calyces associated with progressive atrophy of the renal parenchyma. They go hand in hand. This is due to obstruction to the urinary outflow. The glomerular filtration and the urine production, however, continues. Probably this is why we are getting a hydronephrosis. If there is no further urine production, probably the distension will not be there. But since both are continuing to act, you find that there is a distension. I hope this picture will supplement my statement. So this is a dam, and from the dam you find whenever there is an excess, there is an outflow of water. Imagine what will happen if there is no outflow or an obstruction over here, but the inflow continues to pour in from the various inlets. That will lead to a distension, and that is exactly what a hydronephrosis is. Classification is an aid to orderly thinking. Any number of times I would have said, and it is worth the repetition. It can be congenital, it can be acquired. And it can be bilateral, it can be unilateral. Sometimes it can be regional or sometimes restricted to the kidney or the post-renal region. It can be obstruction, can be within the lumen or it can be outside the lumen. Look at the ways by which we can divide. So this is a very logical sequence which I would like you people to understand. Once you know this, probably the causes you will be able to recollect. Look at this one on my right. These are the causes for an obstruction. It can be because of a calculus, kinking of the ureter, that is, some other structure runs over it. It can be a tumor such as a lymphoma, neurogenic bladder. The bladder loses its neural stimulus as a result of which it does not respond to contraction. And sometimes there is a condition called as reflux. We'll be seeing it. A stricture of the ureter, urethra, etc. Okay. Now let us go to the left side. This is a stupid mnemonic which I liked. All the P's let us try to by heart. There is a condition called posterior urethral valve, phimosis of the penis, papilloma or carcinoma of the trigone of the bladder, prostatic hyperplasia, pressure on the ureter or kinking, pressure on the ureter due to a lymphoma, parasite such as schistosomiasis, plus you can add all this. Calculi, neurogenic bladder or a fibroid uterus. Please remember the P's. Most of the causes you people will be able to recollect. What happens in a case of hydronephrosis? The kidney is enlarged. It can be mild or it can be severe, sometimes 20 to 30 centimeters or even more. There is a specimen in one of the medical colleges wherein the kidney is just like a inflated balloon. There is a distension of the pelvis and the calyces. Pelvis, calyces, all are being distended. Blunting of the apices of the pyramids. You find that these get blunted out. Cupping. You find that there is a cupping of the calyces, and sometimes in this region I am finding fusion of the adjacent calyces, which produce a larger space. And the renal parenchyma correspondingly becomes thinned out. So please describe this one. And usually in a case of hydronephrosis, the inner lining will be smooth and shiny. A little picture is again worth a million words. Look at this one. Nothing to equate a photography of a specimen. I'm finding that there is a distension of the pelvis, distension of the calyces, fusion of the adjacent calyces, and this is what I said. The inner surface is smooth, shiny, grayish white. The renal parenchyma is accordingly thinned out. Still, I am able to see a cortex and a medulla. This is a pyramid that is getting blunted out. A beautiful one, increase in the size. And you can compare it with the normal structures which I do not see. For example, these pyramids I do not find in this region. And the structure of the calyx is different here when compared with this. For your eyes only. Hope you people recollect this. It's a nice movie. And this is again part of a kidney. I find that there is a thinning out of the renal parenchyma. There is a distension of the calyces. And there is a huge horn-like structure that is sitting in the calyx. So this is actually called a staghorn calculus. Staghorn calculus is something that I will be showing you. And this again is, once there is a stagnation, it can lead to an infection. Infection can lead to an inflammation. Look at the inner wall here. You find that it is becoming rough and ragged. It is not smooth and shiny. And here again, it is a case of hydronephrosis in which there has been recurrent cases of infection. Thinning of the cortex, and there is a distension of the pelvic calyceal system. The ureter also appears dilate. And this is a staghorn calculus. The manifestations is, if it is going to be unilateral, it will be asymptomatic because a single kidney is more than enough. But when you do an intravenous pyelogram, you will be able to diagnose it. Bilateral, there is polyuria, there may be nocturia, and because of the polyuria, there is a salt wasting, and there can be a tubular acidosis. So if it is bilateral, all these symptoms can be there. And if it is going to be complete and bilateral, it is not compatible with life. The patient will have to go in for a dialysis. Microscopy, the salient features alone I have mentioned. There is an atrophy of the corticotubular region. There is an obliteration of the renal pyramids, and the interstitium is replaced by fibrosis. Atrophy of the tubules, atrophy of the cortex, obliteration of the renal pyramids, interstitial fibrosis. Remember these words alone. And what can happen is almost the same. It's a repetition in a different way. You find that there is a distension of the pelvic calyceal system, because of which there is an atrophy of the renal parenchyma, and the tubules also, they lose their concentrating ability. However, the glomerular filtration continues. Finally, when it goes in for a renal failure, the glomerular filtration is also suppressed. This will be the sequence of events in a case of hydronephrosis. And why does this happen? Because there is an excretion of the extracellular fluid. The fluid, it keeps coming into the glomerulus and is being excreted. And it has got pressure effects on the kidney. There is also the retained urea. The retained urea will again lead to a glomerular insult. Finally, there is an impaired response to antidiuretic hormone. There tries to be an antidiuretic hormone secretion, but it does not respond, as a result of which there is continuous excretion. All of this can lead to a continuous flow. This is what is happening. There is an outpour from the kidney, and what will happen if there is going to be a distal obstruction? It all gets dammed up and there is a distension. Teaching is not my profession, it's my passion. Dawood Khan. There are many people who are dedicated to education. I think we'll go on to the next topic, a little small, but you will have to by heart. This again is a question for you in surgery. So the types of renal stones. They can be screw-white stones, calcium stones, cysteine, and uric acid. Calcium stones will be the most common, forming about 75% of the causes. So these are the basic types of stones. There is a text over here. Kindly go through it leisurely. What happens here is there is a urinary supersaturation. Because of the supersaturation, you find that some material gets precipitated, and this acts as an nidus or nucleus. Because of the nucleation, you find that more and more material gets deposited on it, and this is leading to a crystal growth. And finally, there is an aggregation of all the crystals. We used to call it as growth by accretion. Accretion means more and more particulate matter are deposited on the top of each other, as a result of which finally we can get a renal stone. There are various factors that are here. For example, a variation in the pH or a damage to the renal epithelium. All of this can lead to precipitation, stagnation itself. So regarding the pathogenesis, I feel this flow chart is more than enough, and you can mention a couple of factors from these. This is another nice flow chart that I picked up, and it gives us an idea as such. Stones are produced because of the variation in the lifestyle, diet, climate, and sometimes occupation also. It can be genetic or sometimes it can be acquired. There are some promoters such as this sodium intake, dietary calcium, etc. And there are some substances which inhibit the citrate and the magnesium. Ultimately, you find when there is an imbalance, there is a formation of the renal stone. And broadly, they can be divided into non-infectious causes, non-infection stones, and infection stones. The non-infection stones are calcium oxalate, calcium phosphate, uric acid, and then the infection will be the screw-white stones. Then there can be some genetic stones such as the cysteine. And the mechanisms are mentioned. What can be the various causes and changes because of this? So hypercalciuria can lead to calcium stones. Alkaline urine can lead to calcium phosphate. And whenever there is an increased turnover, there can be uric acid. Infection can lead to screw-white stones. And defect in the transporter can lead to cysteine stones. So this particular flow chart, I would like you people to repeatedly go through. You need not memorize, because you have to mug up this. This particular tabular column, I would like you people to by heart. The various types of stones are mentioned, what is the incidence, and what is the type of the crystal, whether it is envelope shape or diamond and rhomboid shape. What are the risk factors and the causes for occurrence. So kindly by heart this particular tabular column. I do not want to go into it. Uric acid stones, for example, it is seen in conditions where there is an increased amount of turnover, leukemia, etc. Gout is a condition that is associated with uric acid, and then there can be the uric acid stones. And whenever there is stagnation in the neurogenic bladder, you can get a staghorn calculus, which is quite common. I would like you people to kindly by heart this tabular column, which is most important. Now, what can be the clinical features of the renal calculi? Most common will be hematuria, pain. Sometimes when the stone enters the ureter, the pain cannot be withstood. It is excruciating pain, and you have a relief when it enters the bladder. Similarly, when it enters the urethra also there is a severe pain. The complications can be hydronephrosis, we had seen earlier. And stagnation can also lead to an infection and a pyonephrosis. Rarely, cancer also can occur. And this is the typical stag horn. Stag is a deer as such. And this is a horn of it. You find that it is branching, exactly fitting into the pelvic ileal system. So it is a kind of a cast that is formed whenever there is stagnation and an infection. The type of stone is called as a struvite stone or magnesium ammonium phosphate. Some books call it as a triple phosphate. The methods of treatment will be conservative. You try to treat them with drugs such as diuretics, thiazides, etc. Percutaneous treatment is nephrolithotomy. You try to break the stone. Or sometimes it is because of a shock wave that I try to fragmentize the stones. Surgically also it can be treated by means of a pyelolithotomy, or in certain cases maybe some of this a partial nephrectomy can be performed because the stone is too large to be fragmented. So these are the methods of treatment: conservative, percutaneous and surgical. Blagodario pass. Please try to find out where this is from. Thank you.